for a healthy mother and a healthy baby. This is our main goal, and for this great aim, we discuss this serious topic. Postpartum hemorrhage is one of the life-threatening emergencies. It is one of the major causes of maternal death both in the developing and developed countries. Prevalence of malnutrition and anemia, inadequate antenatal and intranatal care, lack of blood transfusion facilities, and substandard care are some of the important contributing factors. There is also increased morbidity rate. These include shock, transfusion reaction, puerperal sepsis, failing lactation, pulmonary embolism, thrombosis, as well as thrombophlebitis. Late complications include Sheehan syndrome and diabetes insipidus. Epidemiology. Maternal mortality rate in Yemen is one of the highest in the world. And postpartum hemorrhage remains the leading cause of maternal mortality in our country. Definition: any amount of bleeding from or into the genital tract following the birth of a baby up to the end of the puerperium, which adversely affect the general condition of the patient. Evidenced by rise in pulse rate and falling blood pressure is called postpartum hemorrhage. Types: primary postpartum hemorrhage, which occurs within 24 hours following the birth of the baby. In the majority of cases, primary postpartum hemorrhage occurs within the 2 hours following the delivery, and it has two types. Third stage hemorrhage, which is bleeding that occurs before the expulsion of the placenta. True postpartum hemorrhage, which is bleeding that occurs subsequent to the expulsion of the placenta. Secondary postpartum hemorrhage, that occurs beyond 24 hours and within the puerperium. It is also called delayed or late puerperal hemorrhage. Causes: there is 4 basic pathologies expressed as the 4 T's: tune, trauma, tissue, and thrombin. Tune. Atonic uterus is the most common cause of postpartum hemorrhage, accounting for 80% of all causes. Uterine atony can be caused by several things, include grand multipara, over-distension of the uterus, such in case of multiple pregnancy and macrosomia, malnutrition and anemia, antepartum hemorrhage, prolonged labor, some commonly used obstetric medications such as anesthetics, malformations of the uterus such as septate uterus or bicornuate uterus, uterine fibroid, mismanaged third stage of labor. Trauma. Trauma accounts for 20% of the causes of postpartum hemorrhage, and it refers to the damage of any genital structures, the uterus, vagina, cervix, and perineum. This can occur following cesarean section, vaginal delivery, or instruments used in delivery, such the use of forceps, vacuum extractions, or an episiotomy. The bleeding is usually revealed, but also it can be concealed, such in case of vulvovaginal or broad ligament hematoma. Tissue. Retained placental tissues and blood clots can cause postpartum hemorrhage due to imperfect uterine contractions. Thrombin. Blood coagulation disorders, either acquired or congenital, are less common causes of postpartum hemorrhage. The blood coagulopathy may be either due to diminished in procoagulants, such in case of washout phenomenon, or increase in fibrinolytic activity. Diagnosis and clinical effects. The effect of blood loss depends on pre-delivery levels of hemoglobin, degree of pregnancy-induced hypervolemia, speed at which the blood loss occurs. Alteration of pulse, blood pressure, and pulse pressure appears only after class 2 hemorrhage, in which 20 to 25% of blood volume is lost. On occasion, blood loss is so rapid and brisk that death may occur within a few minutes. Symptoms: vaginal bleeding after childbirth, swelling and pain around the vagina, dizziness, lightheadedness, change in vision, palpitations, fatigue, and syncope. Signs: general examination, disturbance in mental status, either confusion, stupor, delirium, or even coma. Pallor of skin and mucous membranes, such as subconjunctiva and tongue. Coldness of the extremities. Vital signs: hypotension, tachycardia, ready pulse, hypothermia, tachypnea, abdominal examination, pain and tenderness that suspects retained placental tissue or endometritis. By palpation, if the uterus is not contracted and soft, this suspects uterine atony. Speculum examination, blood clots, vaginal or cervical lacerations. By manual examination, uterine enlargement, uterine atony, accumulation of blood in uterus. Management of true postpartum hemorrhage. Immediate measures: call for extra help, put in 2 large pour intravenous cannulas, keep the patient flat and warm, send blood for blood count, group and cross-matching, diagnostic tests, coagulation screen including fibrinogen, and ask for 2 units at least of blood. Infuse rapidly 2 liters of normal saline or plasma substitutes. Give oxygen by mask in a rate of 10 to 15 liters per minute. Start 20 units of oxytocin in 1 liter of normal saline IV at the rate of 60 drops per minute, and transfuse blood as soon as possible. Monitor the following: pulse, blood pressure, temperature, respiratory rate and oximeter, type and amount of fluid that the patient has received, urine output by continuous catheterization, drugs, and central venous pressure. Actual management: management of atonic uterus. Massage the uterus to make it hard and express the blood clot. Methergine in a dose of 0.2 mg is given intravenously. Injection oxytocin drip is started. 10 units in 500 ml of normal saline at the rate of 40 to 60 drops per minute. Police catheter is inserted to keep the bladder empty as well as to monitor the urine output. Examine the expelled placenta and membrane for evidence of missing cotyledons or pieces of membranes. And if the uterus fails to contract, proceed to the next step. Step 2. The uterus is explored under general anesthesia. Simultaneous inspection of the cervix, vagina, especially the para-urethral area, to be done to exclude coexistent bleeding sites from the injured areas. In refractory cases, injection of 15-methylprostaglandin F2 alpha 250 microgram IM in the deltoid muscle every 15 minutes, up to the maximum of 2 mg. Or misoprostol, which is prostaglandin E1 in a dose of 1000 microgram, is given per rectum. When uterine atony is due to tocolytic drugs, calcium gluconate should be given to neutralize the calcium blocking effects of these drugs. Step 3. Uterine massage and bimanual compression. Step 4. Uterine tamponade, tight intrauterine packing, balloon tamponade. Step 5. Surgical methods: P-Lynch compression suture and multiple square sutures, ligation of uterine arteries. Step 6. Hysterectomy. Traumatic postpartum hemorrhage. The trauma to the perineum, vagina, and cervix has to be searched under good light by speculum examination, and hemostasis is achieved by appropriate catgut sutures. The repair is done under general anesthesia if necessary. Prevention. Postpartum hemorrhage cannot always be prevented. However, the incidence and especially its magnitude can be reduced substantially by antenatal care to detect any risk factor in pregnant women. Any medical problem in pregnant women such as anemia or other should be treated as soon as possible. Instruct the pregnant woman to correct anemia before birth by using iron supplements and consuming foods that are rich in iron. Blood grouping should be done for all women so that no time is wasting during emergency. Women with identifiable risk factors should be delivered in good hospital with blood transfusion and ICU facilities. Instruct the woman to go to hospital when enter labor stage to get correct follow-up. Serial ultrasonography in high-risk women to detect the state of the baby and the placenta. Active management of third stage of labor is the best preventive strategy you can use. Intranatal measures. The placenta and membranes should be examined after delivery to exclude any missing fragments. Cases with induced or augmented labor by oxytocin, the infusion should be continued for at least 1 hour after the delivery. The uterus and birth canal should be explored after any instrumental delivery as forceps to detect any tear. Every patient should be observed for at least 2 hours after delivery to detect any postpartum hemorrhage. During cesarean section, spontaneous separation and delivery of the placenta reduces blood loss up to 30%.